opening the door wide to new possibilities, hope of real breakthroughs and understanding more big ideas than we could have ever imagined. These are the biggest grants we've ever been able to offer. We're going to come out of this with some breakthrough ideas.
Focused solely on neuroendocrine tumors. You are not alone. We are all with you on this. Let me, without any further ado, introduce Dr. Woolen again. Dr. Woolen has been such an amazing educational partner for us, helping to really carry the word and caring for patients throughout the United States and the various places he's been. He's really one of the go-to guys in this field, and it is my pleasure to have him as our co-chair and introduce him to give an overview today. So, Dr. Woolen.
Thank you for your kind words. So what I'm going to do right now is to give an overview of neuroendocrine tumors, what they are, what is a carcinoid, what is a neuroendocrine tumor, primarily designed for people who have recently been diagnosed and are just overwhelmed by lots of technical data. And it'll also make the rest of the day much more understandable if we all agree on basic principles and definitions. First of all, neuroendocrine cancer is one of the very fastest increasing cancers in the United States. The incidence has gone up by 500% in the last 30 years. A little of that could be due to early diagnosis, but I suspect a lot of it is actually more cases. It's also become exceedingly prevalent. It's the second most prevalent gastrointestinal malignancy in the country. Gastrointestinal neuroendocrine tumors are second only to colon cancer. There are roughly 1 million patients with colon cancer and 100,000 with neuroendocrine cancer. So the prevalence, the amount of patients in the United States with this kind of cancer exceeds stomach cancer and pancreas cancer put together, which is really an extraordinary figure. So it's not as rare as we think it is, and it certainly as rare as it used to be. See if it's going to work now. Okay, neuroendocrine cancers are classified in several different ways, but the first item is where do they start in the body? Where they start in the body is generally divided into 3 major subgroups determined by where the cancer cells might have been if you were an embryo, where in the embryo the cancer would have started. In an embryo, which is the picture you see here on the right, okay, it's divided into foregut, midgut, and hindgut. None of those structures exist in adult people, but we call neuroendocrine tumors foregut neuroendocrine tumors, midgut neuroendocrine tumors, or hindgut neuroendocrine tumors. The foregut tumors have sites like thymus, esophagus, lung, stomach, duodenum, pancreas. There's a midgut site that is primarily small intestine, but also includes appendix and parts of the colon that are next to the small intestine, and the hindgut, which is primarily rectum. So these are the major categories, and there are actually biologic differences between these 3 groups, differences in response to treatment, and differences in biology. 25% of intestinal carcinoids are multiple. So it really takes an experienced surgeon to do an operation and to take it out properly, because there could be other tumors that could be left behind. Approximately 25% of people who have an intestinal carcinoid tumor or intestinal neuroendocrine tumor, it's another name for that, have something that looks multiple. And this is an example of somebody who really has quite a few. Another basic principle of neuroendocrine cancer is they come in different degrees of aggressiveness. The higher the grade, the more rapidly the cells grow, the faster they spread, the faster they come back after surgical resection if they're destined to come back. So we call them grade 1, grade 2, grade 3, also known as G1, G2, and G3. The higher the grade, the faster the growth. So how do we determine the speed of growth? We do it by analyzing the number of cells that are dividing. So a pathologist can look at the cells under the microscope and count the number that are undergoing cell division. We call that mitosis. And if you have more than three or more mitoses in a high-powered field, we call it grade 2. And if you have more than 20, we call it grade 3. The other way of doing it, which is even more accurate, is to apply a chemical test to the cells called Ki-67 or Ki-67. This is a chemical reaction that only takes place in cells undergoing cell division, and then you could count them up, or you could even use computer-assisted image analysis and scan very large numbers of cells to determine a percentage of cells dividing. If this number is 1 or 2%, it's called grade 1. If it's more than that, we call it grade 2. If it's more than 20, we call it grade 3. Carcinoid tumors, well-differentiated neuroendocrine tumors, the kinds of tumors we're talking about today, are all going to be in the well-differentiated category. They're all going to be grade 1 and grade 2. Since we have several people in the room with lung carcinoids, I just want to mention that this system does not apply at all to lung. Pathologists have not been able to agree among themselves what the cutoff should be for Ki-67, and instead rely entirely on other criteria like mitosis and necrosis. The next concept I want to leave you with is that some carcinoid tumors, or neuroendocrine tumors, are able to make hormones. These are cancers that start from endocrine cells, and the natural function of an endocrine cell is to make hormones, to make chemical substances that go into the bloodstream. The ones that make chemicals that you could measure and cause a syndrome caused by too much hormone are called functional neuroendocrine tumors, and the other ones are called non-functional. So in the world of pancreatic neuroendocrine tumors, the non-functional ones that make up the majority, and some of them make substances that are like pancreatic polypeptide or chromogranin, but these are not causing a syndrome, so we call these non-functional. The functional ones make things like insulin or glucagon or somatostatin or VIP or a bunch of other hormones, and these are called functional neuroendocrine tumors of the pancreas. In the world of intestinal carcinoids, neuroendocrine tumors of the intestine, the most common hormone by far is called serotonin, and when you have too much serotonin in the body, you can get something called carcinoid syndrome. That's a set of symptoms that result from having too much serotonin. And the most prominent features are flushing and diarrhea, but they also can cause the heart to beat rapidly, to cause tremendous anxiety, to injure the heart, and to cause a variety of other things that we'll be talking about in a little bit. Now, one of the questions is, when is flushing a sign of carcinoid tumor? We see people with red faces all the time. And a lot of people Google on the internet and say, what causes a red face? And it says carcinoid, and they come rushing to carcinoid support groups and carcinoid physicians, thinking that they actually have a carcinoid. But everybody who looks red does not have a carcinoid. Flushing is actually caused by dilatation of the blood vessels right beneath the surface of the skin. And since the skin of the face and neck is the thinnest skin in the whole body, that's the area where you see the redness the most. And really anything capable of making blood vessels get a little bigger under the skin can make you look red. And this includes things like menopause, blushing, exercise, fever, hot drinks, alcohol, allergic conditions with too much histamine, rosacea, other kinds of neuroendocrine tumors in addition to carcinoid. So it really needs to be sorted out by a physician, dermatologists, oncologists, endocrinologists. Anybody who sees people who are flushing needs to be aware of the complex issues involved in diagnosis. And we have many patients where more than one of these causes can be going on at the same time. Things like menopause or blushing can happen very commonly in the population, and it's possible to also have carcinoid syndrome with true carcinoid flushing. It's also worth noting that carcinoid flushing is usually not associated with sweating. It's not an absolute rule, but it's more commonly not associated with sweating, and menopausal hot flashes usually are associated with sweating. This is a picture of somebody who has a pretty prominent carcinoid flush. Carcinoid diarrhea is also a special type of diarrhea. Diarrhea is exceedingly common in the population. Irritable bowel syndrome is exceedingly common. It's one of the reasons why so many people with carcinoid syndrome are misdiagnosed, because when doctors hear hoofbeats, they think of horses and not zebras, and the zebra with the carcinoid having diarrhea from carcinoid syndrome actually appears periodically, and I'm sure it's happened to many people in this room. The diarrhea that comes from carcinoid is a so-called secretory diarrhea with large volumes of stool coming out, whether or not you're drinking or eating a lot. And Dr. Metz is gastroenterologist, very experienced in carcinoid, and will be talking about these things, and also Julie Yang, gastroenterologist, who will be speaking later about diarrhea. So just be aware that it's a complex issue, and there also are many, many causes of diarrhea in carcinoid patients in addition to serotonin production. And again, that will be discussed later in the conference. One of the most feared complications of too much serotonin is injury to the heart. You can actually get scarring of the heart and damage to heart valves. This is associated with particularly high levels of serotonin, typically greater than 1,000, and typically very high levels of urinary 5-HIAA. You don't have to have a tumor in the body for a really long time. I've seen this happen in less than 6 months in some people with tremendously high levels of serotonin, but it does happen almost always with very high levels of serotonin. The valves that get damaged tend to be the ones on the right side of the heart. The tricuspid valve and the pulmonary valves are the ones that get injured first, although certainly you can get injury to the left-sided valves in certain circumstances, like if you have a hole in the heart connecting one chamber to the other. When you have damage to these valves, you typically have swelling in your legs and your abdomen, shortness of breath, fatigue, and management is difficult and often requires actually replacement of the damaged valves when this condition becomes severe. Another thing to remember about carcinoid syndrome when you have a lot of serotonin is it causes scar tissue to form, what doctors call fibrosis. You can get fibrosis, scar tissue in the abdominal cavity that can lead to obstruction of intestines. You can get scarring in other tissues in the body, not only the heart, but you can get scarring in the area behind the abdominal cavity, and you can even have so much scarring that it can block off the major blood vessels bringing blood to the intestines, and that can be a very serious problem. You can have a deficiency of the essential amino acid niacin. It comes from, niacin is made from the dietary amino acid that we eat in all of our proteins called tryptophan. It's a natural amino acid. The body turns that amino acid into niacin, which you need to live, and it also turns it into serotonin. In the case of having a carcinoid, you can make so much serotonin that you use up your tryptophan, don't have enough niacin, and you actually can have a vitamin deficiency, which causes a rough, red, scaly skin, mental confusion that can also cause diarrhea, and people sometimes think this is all part of carcinoid syndrome, but it's actually a separate vitamin deficiency disease and can easily be treated or prevented by using niacin, an over-the-counter vitamin. Rosacea is a chronic red, thick skin around the face and neck and upper body, which has a variety of causes, but the bottom line is that any cause of chronic flushing can lead to rosacea, and people that have uncontrolled flushing for long periods of time can end up with this condition, which can be diagnosed by their dermatologist as rosacea, and the dermatologist might not even be aware that it's coming from serotonin and carcinoid syndrome. Okay. Now, another principle that has already been mentioned by Ron Hollander is that it's unfortunately difficult for people to make a diagnosis of carcinoid early on. This was a famous graph that was made by Dr. Aaron Vinnick years ago, which shows the white line is supposed to represent the natural history of carcinoid disease. And by the time people actually have flushing and diarrhea, they may have had the disease in their body for 10 or more years, and then they get diagnosed. If you look at the survey of American patients, 758 patients, if you see the results that Grace Goldstein is going to be discussing with you in great detail very shortly, 53% of patients needed more than 2 years to make a diagnosis, and 34% needed more than 5 years. So we're trying to educate patients about their disease, but we're also trying to educate doctors every chance we get so that people can be diagnosed at a time when it's early and most treatable. So I'll be speaking later about treatments of neuroendocrine tumors, but I wanted right now just to give you this overview. Thank you very much.